I think we can start. Now it's 1:30 p.m. and I'm happy to introduce you to the next session of this workshop. This is an afternoon session, the perspectives in health disparities research. I'm the chair of this session. My name is Julia Kravchenko. I'm from the Department of Surgery, Duke University School of Medicine. And we have today 4 presentations in this session, 30 minutes each presentation. You can post your questions in the questions and answers on the bottom of the screen. If we'll have some time left after presentation, the presenter could answer the question just immediately after presentation. Otherwise, we have a round table that will start at 3:30 p.m., 1 hour round table. And we can also discuss the responses to your questions at this round table. So I hope we can move forward. And actually, the first presentation is mine. So I'm happy to present my topic. Just 1 second, I will share the screen with you. Okay. Can you see the screen?
Yeah.
Okay, thank you. So my presentation is on disparities in Alzheimer's disease, its current status and future perspectives. Just 1 second. I cannot list it. I don't know why. Some technical issue. Okay, now it works. So this is some picture on a global keywords map. So you can see that since 1988, the publications on Alzheimer's disease increased dramatically. And on the left, the topics. And now we see in 2017, that's actually almost 5 years ago, but we see how many different topics now are published on Alzheimer's disease and dementia. And on the right, these 2 figures, it's the countries. And now we see how many countries join the research on Alzheimer's disease and dementia. And that's just larger view to one of these pictures. And you can see in the circle, it's the topic mostly I will discuss right now. It relates to clinical studies, epidemiology, population health studies, systematic reviews, and cognitive reserve. And of course, I understand that 30 minutes is definitely not enough to describe all aspects of this very important and very large topic. And in this presentation, I would present just several aspects. And mostly the data I will present is based on some meta-analysis. And I will try to identify, of course, not all gaps, but at least several gaps that we could address in nearest future. So this is NIA Health Disparities Research Framework. And you can see that fundamental factors are ethnicity, gender, age, race, disability status, and identity. And we have 4 main domains like environmental, socio-cultural, behavioral, and biological. And within these, each of these domains, we have different groups of the factors, and we could have disparities in 1, 2, or usually it's 3 or more factors simultaneously. And these are publications on disparities from 2002 to 2022. And so you can see that number 1 in publications is on keyword health disparities. It's followed by gender disparities and racial disparities and social economic disparities, and then gender disparities. And we can see that the number of these publications growing over time, especially for keywords health disparities, racial disparities, and social economic disparities. And the last right part of the graph, it's just for only 2 years. So even for racial disparities, we can see that during these 2 years, we have already increased. So we see that this topic became more and more important. On Alzheimer's disease-related dementia summit in 2016, the national research priorities in health disparities have been formulated the way you can see here. And you can see here 4 focus areas. The first one on treatment and prevention strategies, the second on monitoring changes in DRD disparities. The third is assessment, and the fourth is community partnerships, recruitment and retention. And there are just with red line, I highlighted the words in these priorities, which you will see, repeated during my presentation as being in focus in this presentation. That's assess epidemiology and mechanistic pathways of disparities, the magnitude and trends in health disparities in incidence, and also I could add in prevalence and mortality of Alzheimer's disease, and leveraging existing data and cohorts. So as to the health disparities, this is a very wide group of disparities. This is why so many publications have been already published on this topic. And I will definitely not cover all aspects of health disparities in this presentation, but just will highlight several important aspects for current studies. The first one is age. So here you can see age distribution of patients below and above age 80. And this data is from clinical trials. And also you can see that the number of patients with Alzheimer's disease in the USA is opposed to the number of clinical trial participants. So you see that age of the participants does not reflect the actual distribution of patients in the general population. And individuals aged 80 and older contribute greatly to the number of people with Alzheimer's disease, and their proportion is expected to grow further in the coming decades. This is why it's important to include into analysis this group of population and work with data set that provides information on this very important age group. The next aspect we need to take attention to when studying health disparities is undetected Alzheimer's disease. And you can see the meta rate of undetected dementia by location of study for different countries and parts of the world. And you can see that in US, we have over 60% of dementia undetected. And that provides us with some focuses of further studies. So we need to take it into account when doing our analysis. We need to investigate patterns of mixed dementia and its component, not to lose an important information. And that's a question about accuracy of administrative claims data in quantifying and distinguishing cognitive disorders. Another important aspect of health disparities in Alzheimer's disease is multimorbidity, comorbidity, and their role in health outcomes of patients with Alzheimer's disease. Critical gap remains in understanding the relevance and temporal occurrence of multimorbidity patterns. And the methodologies for carrying out these types of analysis are still nascent. Most analysis of multimorbidity in Alzheimer's disease consider chronic condition assessed mainly by the number. So, but the ways, the mechanisms related to specific combinations of disease could be overlooked if we will take into account just number of conditions. without the nature type of these conditions and their combinations. It is important to use novel statistical approaches rather than a simple enumeration of chronic conditions. And it's important to design research studies to account for combinations and patterns of comorbid diseases, their interrelations, and their overtime dynamics. Currently, little is known about how Alzheimer's disease, dementia, and other significant cognitive impairment impacts morbidity and mortality for people with multiple comorbidities, including, but of course not limited to, such diseases as diabetes, chronic pain, cardiovascular disease, depression, falls, and stroke. And it's also important to take into account that when studying effect of treatment, we can observe different impacts on the risk of dementia or Alzheimer's disease from the same medication prescribed for patients, prescribed in patients with different types of comorbidities. For example, it has been shown that antidepressants had opposite dementia risk depending on whether the medications were prescribed for depression or for migraine. Selective serotonin reuptake inhibitors increase dementia risk when used to treat depression, but decrease dementia risk when used to treat migraine. Next very important aspect, I will describe it very briefly, but I had to describe it. It's in health disparities and Alzheimer's disease is the COVID pandemic in patients with Alzheimer's disease. Here you can see contribution of leading causes of death to the changes in life expectancy, which is dramatically reduced during the period of the COVID pandemic. And we can see that, for example, in males or in Hispanics patients, Alzheimer's disease still have positive impact on improvement in life expectancy even during the COVID pandemic period. But if we will look at monthly patterns of mortality rates from the provisional multiple cause of death data, 2018-2022, it showed substantial increase of mortality among Alzheimer's disease patients. And this mortality peaked predominantly in late spring or winter 2020-2021. So in winter, peak was observed predominantly for white patients, in early spring 2020 for Black patients with Alzheimer's disease. On these graphs, the blue and violet curves represent mortality among patients with Alzheimer's disease, including those who had COVID in death record, just all patients with Alzheimer's disease. Violet curve before pandemic and blue curve during pandemic, and green curve, it's provisional data during pandemic. Red curve, it's mortality among Alzheimer's disease patients without COVID in death records. And we see that for addition to, as we can see here, race-specific differences in pattern of mortality between white and Black patients with Alzheimer's disease who died from COVID, we also see increased mortality that was not directly related to COVID. I mean this red line. And it was more substantial compared to pre-COVID period among Black patients with Alzheimer's disease. It could be due to relocations of medical resources, low access of medical care, for example, limited use of telemedicine, non-COVID complications caused by the earlier COVID infection, or underdiagnosed and or unregistered COVID cases in Alzheimer's disease patients or other causes. So it's definitely also will require further studies. Now we will move to the racial disparities in Alzheimer's disease. Let's talk about Alzheimer's disease prevalence and incidence. We see that estimated prevalence of Alzheimer's disease in the US population age 65 plus is the highest among African American, following by Hispanics. Large gap remains in the scientific understanding of Alzheimer's disease prevalence and incidence in diverse US population. High odds of elevated brain amyloid in Black, after adjusting for other risk factors such as APOE, age, cardiovascular disease, could provide some explanation for higher rates of Alzheimer's disease in this population group. Also, just one second. Also, most cognitive measures are influenced by linguistic, educational, or cultural factors. And the availability of norms for individuals with little education remains limited. So that's definitely a lot of what we need to do to investigate these patterns and understand why in the diverse US population it's so different. Let's look at Alzheimer's survival and mortality. Differences in mortality in minority ethnic groups, we see that it's compared to white population, it's the much lower for Black population, for example, also for Hispanic and Latina and non-white. And racial ethnic differences in survival following Alzheimer's diagnosis also are not widely studied. Black and Hispanic Latina groups may have lower hazard of dying after Alzheimer's disease diagnosis. Differences in cognitive reserve or greater resilience, tolerance, and compensation capacities could explain these observed differences. Black patients has been shown to have slower rate of cognitive decline over time compared with non-Black patients. The systematic inflammatory differences and the immune changes related to cardiovascular diseases also highlight the potential for significant ethno-racial differences that could have implications for Alzheimer's disease progression and treatment. It's a very important topic, race representation, when we talk about racial disparities. If we'll see these figures, so that's geographic location of clinical sites for 49 included studies, and on the bottom we see race representation in randomized controlled trials. And we see that there is definitely underrepresented Black population as well as Hispanic, followed by Asian. Race should adequately be considered in research and drug development protocols targeting Alzheimer's disease. The research community continues to improve recruitment of diverse populations into clinical trials of Alzheimer's disease. Recent efforts by the NIA, with the support of the Alzheimer's Association, are developing a national strategy for clinical study recruitment and retention, with a direct emphasis on diverse recruitment strategies. Black patients are less frequently prescribed medications overall for Alzheimer's disease and discontinue this medication more frequently. Data analysis and racial disparities. Findings from much of existing research base may not apply to the population groups that are most severely affected by Alzheimer's disease. For example, the optimal cutoffs for detecting Alzheimer's disease differ by racial ethnic status and may result in misdiagnosis or overdiagnosis in these groups. Limitations of generalizability and applicability of findings on Alzheimer's disease treatment and management is also an issue. This is important to implement analytic methods to weight observations from underrepresented groups to attenuate the impact of small sample size. Development and validation of research tools that can be used across race ethnicity specific groups, development and novel tools that are group specific, and the development of appropriate analytic methods for working across the tools is also important for analysis of racial disparities in Alzheimer's disease. To test ethno-racial factors within the context of a big picture, including but not limited to factors such as gender, neuropathology, molecular biology, social economic characteristics, environment factors, and more. Multi-scale modeling, advanced artificial intelligence learning tools and structural equation modeling are some of the tools that are explicitly designed to manage such large-scale and complex analysis. So now let's talk a little bit about gender disparities. So women suffer greater cognitive impairment across a wide range of cognitive domains. The prevalence and effects of cardiovascular, cerebrovascular disease, metabolic disorder, major depression, ApoE genotype, and social economic factors differ among males and females. So this picture shows brain atrophy in women and men with amnestic mild cognitive impairment over 1 year period. And we can see that brain atrophy rates shown in blue and patterns differ along the Alzheimer's disease continuum between males and females, especially at younger ages. Brain atrophy is faster in females than in males. This picture shows studies on 6 differences in Alzheimer's disease based on 134 PubMed publications. And we can see that, for example, the most often publications on gender disparities on Alzheimer's disease was on brain transcriptome, brain imaging, and brain clinical data. In general, it has been shown that over 75% of the studies showed female-specific changes at molecular levels in the brain, blood, or cerebrospinal fluid. And only about 20% studies showed male-specific changes. If we will look at Alzheimer's disease mortality, we see that female-male gap in Alzheimer's disease mortality is the widest starting 2016. So it becomes wider, during recent 2 decades. Males and females might require more gender-specific approaches to their treatment and to the care. And also there are gender-specific resilience factors that could have implications for different care strategies to ameliorate cognitive decline. For example, females carrying Alzheimer's disease genetic risk may especially benefit from early interventions that target improvements in cardiovascular, respiratory, and mobility function. And males with Alzheimer's disease genetic risk may benefit from combined interventions that target physical fitness, treatment of depressive symptoms, and everyday cognitive activities. Future population-based and clinical data analysis for gender disparities could be described as following. So it's secondary analysis of existing longitudinal data sets or biomarkers of Alzheimer's disease. It's evaluation of gender-specific cutoff values for diagnostic biomarkers. It's meta-analysis of sex differences across multiple clinical studies. It's adjustment of analysis for comorbidities with specific focus on gender-specific comorbidities. The data stratification by menopausal state of women, if possible. Study gender-specific risk factors and predictors in large longitudinal data sets, including large administrative data sets. Consider gender, genetic predisposition, and gender-specific risk factors when developing risk scores for Alzheimer's disease. Consider gender-specific differences in the analysis of social economic characteristics and social constructs, and publication of sex and gender studies with negative results to avoid publication bias. Now we'll talk about social economic factors and social economic disparities in Alzheimer's disease. So here on the left, we see associations between low educational level and later risk for dementia based on the meta-analysis, which is almost twice as higher. And on the right, we see associations between early life food deficiency and later risk for dementia, which is also almost twice as high. Of course, we cannot go deep into this very important, very interesting, and very high demand topic right now. But what we can stress that in terms of social economic factors analysis for Alzheimer's disease risk, so future research could be focused on analysis of social economic factors as a multidimensional construct, when social economic factors on individual level and area-specific social economic characteristics will be analyzed together. Also, we can focus on analysis of social constructs and Alzheimer's disease risk and outcomes. Methods to evaluate social economic effects on health-related disparities using administrative, population, and clinical data are very important for this task. We can do an analysis of the role of social economic factors using a gradient approach compared to analysis of population groups, which are divided based on their income, educational attainment, and more. Geographic disparities. So you saw this figure yesterday. Dr. Igor Yakushevich presented it, so I will briefly describe it. It's total age-adjusted death rates from Alzheimer's disease averaged over 1999 to 2018. And we can see substantial differences in Alzheimer's disease death rates in the US. The highest in Washington state and the lowest in New York. And excuse me? Okay, I just had some sound here. Okay. So diseases of nervous system contributed greatly to this difference from the side of Washington state, and circulatory diseases in New York. Diseases that showed similar to this between the state differences in mortality were stroke and its sequelae, Parkinson's disease, vascular dementia, and falls. Between the states differences in cause of death, coding practices did not contribute to the differences in Alzheimer's disease mortality. Also, it has been shown that Blacks and whites born in the United States stroke belt are at higher risk of dementia mortality than those born in other states, even for people that moved out of this region. And geographic disparities are definitely an important type of disparities we need to study further for Alzheimer's disease patients. And further progress in explanation geographic disparities can be made through analysis of survey data and health data, such as Medicare, linked to multiple cause of death data, to test whether the patterns observed in the multiple cause of death data can be predicted by incidence-based mortality. Also, it is important to perform analysis of competing risks from cardiovascular diseases, hypertension, other conditions. Analysis of access to care and quality of care data to identify the role of healthcare domains in geographic disparities in Alzheimer's disease risk and outcomes. And further research on the role of place-based variations in modifiable behavioral risk factors, treatments of comorbidities, social characteristics, social constructs, and other factors in geographic disparities of Alzheimer's disease incidence, prevalence, survival, and mortality. And let's briefly talk about environment risk factors, which are growing concern during recent decade. It has been shown that exposure to higher levels of particulate matters associated with higher Alzheimer's disease risk. And you can see that on this graph. And future research in this important area includes analysis of impacts of ambient particulate matter, arsenic in water, and other factors on disparities in Alzheimer's disease risk and outcomes across the US. Analysis of the spectrum of metals and their concentrations in particular matters, which are specific for certain geographic areas. And specific components are accounted with specific disease risks. Also, it's important to investigate the role of environment injustice and discrimination for populations at risk. It is also important to develop the methods to evaluate environment effects on health-related disparities and using administrative, population-based, and clinical data. Current limitations to work on include the absence of measures of individual exposures, history of residence for a long period of time, not accounting for traffic noise as potential risk factor for Alzheimer's disease and dementia, and not accounting for variations in exposure to particulate matters within a small area. Why it is important? Since the opportunity of each individual to control environment contamination pretty limited, further regulations of public exposures to contaminants could provide a great potential for improving neurocognitive health in at-risk US populations. And here is the brief summary of analysis of disparities, a brief summary from this presentation. Due to disparities in access to specialty diagnostic care, current Alzheimer's disease data set are lacking in research data on from diverse populations. There is a critical gap in our knowledge about the evidence-based interventions that are applicable to and effective in underrepresented groups of patients with Alzheimer's disease. The emphasis on analysis of interrelations and interactions among variables becomes increasingly important for understanding disparities in Alzheimer's disease and dementia. Shifting away from research designs that emphasize singular explanations for disparities in cognitive impairment, Alzheimer's disease, dementia, in favor of the methods allowing for capturing the multi-level underlying differences is very important. And the NIA Health Disparities Research Framework includes a multi-level approach encompassing environmental, socio-cultural, behavioral, and biological processes. Using complex methodological topics such as decomposition methods, partitioning analysis, Bayesian methods, latent structure analysis, instrumental variables, and other methods of causal inference and design analysis simulation methods also would provide new information on analysis of disparities. The integration of demographic, genetic, epigenetic, biomarker, and clinical data from large studies into predictive models will require the use of machine learning and artificial intelligence. Routine mortality statistics may underestimate Alzheimer's disease mortality. Therefore, the disparities obtained from the multiple cause of data should be reproduced when incidence-based mortality calculated from large administrative data sets, for example, such as Medicare records. And involvement of Medicare records could identify possible disparities in Alzheimer's disease incidence and survival, which can be analyzed through partitioning and can be used to track the health status of individuals involved in cross-state migration. And thank you very much for your attention. And I would like to join, celebration today for all my female colleagues. And every woman is special in her own way, and happy Women's Day. Thank you. Okay, so I just used my 30 minutes. If you have some questions, you can leave these questions using the questions and answers at the bottom of the screen. And then we can discuss and I can respond these questions during the roundtable.